The number of patients that receive care at an HTC varies based upon the patients and the parts of the country that we service the patients in. If I had to give a range, I would say that we have 40 to 50% of the total patient population with hemophilia that are seen in hemophilia treatment centers. The amount of coordination that we do with the HTCs varies based upon the HTC, their protocol, and how they wish to work with us as a specialty pharmacy. We, at many times, are providing the HTCs with regular reports back of patient status, patient condition, the refills for factor products, and many other pieces of information, including if we are providing nursing, the results of the nursing visit, including the nursing notes. So we customize what we do specifically for the HTCs based upon their protocols and based upon the types of information that they wish to have exchanged with them. Specialty pharmacists assist in managing the high cost of inhibitor patients by keeping regular communications occurring between the patients and the hemophilia treatment centers or the physicians who are providing the care. Frequently, we are able to determine that a patient is at risk or beginning to develop an inhibitor by looking at treatment patterns and infusion patterns with the patients. And when we see something that the patient might be not responding or maybe getting to use more factor to treat their bleeds versus what they've used previously, we then make sure that we work with the treatment centers and the physicians to communicate what we are seeing so that the patients can be assessed quickly by their physicians. What we also are able to do is assure that we have appropriate inventory of the different factor products for inhibitors and assure that we are dispensing and coordinating the inventory for the patients in their homes as best as possible to assure that they have what they need to infuse and that the therapy that is being given is the best therapy for the patient. Our pharmacists and our nurses do regular clinical assessments of the hemophilia patients. When they determine that there has been a change in their factor infusion patterns, the number of bleeds they have, or any other situations that might be a sign for inhibitor development, we then make sure that our pharmacists or nurses reach out to the physicians to notify them of what they have seen and assessed. There is not a specific protocol to refer to a specialist. What we do is coordinate directly with the patient's physician, and if there is a need for the patient to be referred outside of their normal physician-patient relationship, then we are able then to suggest referrals for specialists or work with a physician to coordinate that. We as specialty pharmacists work with the physicians, the treatment centers, to determine what factor products would work best with patients given their lifestyles. For the longer-acting factor replacement therapies, we are able to work with the patients to determine if they would prefer fewer infusions, if they are responding well to treatment and can move to a longer-acting product, or any other type of situation that might be arising where we would make recommendations based upon what we're seeing and what might be best for the patient. Whenever we are looking at longer-acting factor products, we are not only looking at the products clinically, but also from a cost perspective. Given that patients have different insurances, and under those insurance plans, different factors are covered at different rates, including copays and deductibles and things such as that. We will take cost into play as well as a clinical evaluation in working with the physicians and treatment centers to determine if the higher cost, longer acting products are appropriate for the patient financially, not just clinically. There are quite a few factor products in the pipeline, and we will have more options in years to come than we do today, which is even better today than what we had 10 years ago. What we will be seeing the specialty pharmacists doing in 2 to 3 years is understanding the differences amongst all the products and providing a much more consultative approach to the physicians and treatment centers to help them manage the selection of the products. I think that when you look at adolescents or young adults who have hemophilia, they are no different from any other adolescent or young adult out there when you're trying to work with them, convince them to do something, or to work with them and have them take responsibility. When we look specifically at hemophilia patients and having them own their treatment regimen, we've seen a couple things that work in particular, and it is not a single approach that usually works. First, having that relationship with the nurse who is working with the parent caregiver to do the infusion, and having that nurse be a voice to transition the infusions from the parent caregiver to the adolescent young adult has been very well received because the nurse is viewed as a trusted member of the family and of the treaters. We have also seen that hemophilia camps where the adolescents can go off and spend some time in the summer with people like them has also contributed, because then you have that peer pressure from their fellow hemophiliacs that is leading to them owning what they need to do. And then, of course, you can't substitute the impact of the parent caregiver and having them have the right tools, having them have discussions, and working with their children to help them transition to owning their treatment regimens. What we typically see is when we have hemophiliacs who wish to participate in sports that might have the propensity to create more bleeds in patients due to the type of sport it is, it usually involves a conversation with the patient, the parent caregiver, and the physician or treatment center to discuss what will be best and what is needed in order to participate in that sport. Certain sports should be avoided, but even so, other sports still have risk to increase the number of bleeds that a patient might have. We also look at costs, because if you are going to be infusing more factor, then the patient's insurance, the cost of the patient for co-pays, things such as that have to be factored in. So we really like to look at the whole picture, let them know up front what the risks might be, but also balance that with the benefits of having that hemophiliac participate in sports and have an active lifestyle, which overall leads to a much better quality of life. We definitely have payers who are specifically interested in how we are managing the factor products for hemophilia patients. So from that aspect, we do tend to provide reports back based upon our recommendations or based upon what they are asking us to do. That does include bleed logs, whether they are having episodic treatments in addition to their prophylaxis, and particularly assay management reports that discuss how closely we are able to dispense product to this prescribed factor dose. Whenever we're looking at inventory for a hemophilia patient, we are working with the physician to determine what the physician would recommend, but also as we develop history with the patient, their bleed patterns, and their activities, we determine what they need to have on hand so that they can appropriately infuse the factor products if they have an episode. We also look at things such as geography, and if they are not near a hospital or a center of excellence, a hemophilia treatment center, and it would require a long drive, or they might be in a remote area where at times of the year due to snow or other types of weather phenomenon that it might make it difficult for them to get the factor or to go to a place to be infused. We also factor that in whenever we're looking at how many doses should be on hand.